So we'll go ahead and call up Dr. Stemler up to talk about use of, the potential drug-drug interactions of antifungal prophylaxis and midostaurin, which is an important FLT3 inhibitor in acute myeloid leukemia, the clinical implications. Thank you very much, Dr. Stemler. So if you want, maybe you could just say a little bit about the background of the two books.
I'll probably start with that part of the presentation because most of you might be well aware of the data. So first of all, I'm a clinician, so I'm going to talk about this topic from a clinical perspective and mention the role or the potential of therapeutic drug monitoring for this AML cohort. So on behalf of all my co-authors, I'm going to talk about this topic and present some preliminary data from our patients at University Hospital of Cologne, which we treat with midostaurin and posaconazole concomitantly. This is my transparency declaration. And a few words on the background. We know that triazole-based antifungal prophylaxis in AML very efficiently decreases incidence of invasive fungal infections and even improves overall survival. And this is mainly based for triazole and for posaconazole. And on the other hand, novel targeted therapies in acute myeloid leukemia have come up. And among them, midostaurin is a FLT3 inhibitor, which has been licensed in 2017. With improved overall survival in a large cohort of intensively treated AML patients. And this drug is a subset of the CYP3A4 system, which you might be well aware of. And posaconazole among the azoles is a strong CYP3A4 inhibitors, and therefore concerns among treating hematologists and infectious disease physicians have come up that potential drug-drug interactions may menace those patients. So the aim, of course, in the clinic should be to continue both drugs concomitantly, as both have shown a survival benefit. Different strategies have been adopted, like dose reduction of midostaurin or switching antifungal prophylaxis from triazoles to echinocandins and so on. So there was really some kind of insecurity due to the lack of data. Now we have some data from the subgroup analysis of the RATIFY trial, which led to the licensing of midostaurin in patients who received strong CYP3A4 inhibitors. And what they saw was that patients with strong CYP3A4 inhibitors had almost a 1.5-fold higher midostaurin exposure. And in those patients, there was an earlier onset of grade 3 and grade 4 adverse events. However, numerically, those were not higher, but some very severe grade 4 pulmonary toxicities were observed. This was the basis for us to design a study including TDM. That TDM can play a role and is really significant in patients receiving posaconazole, has been shown by our Italian colleagues here, where we see here on the left-hand side that patients, 3 higher bars, who received posaconazole really had higher midostaurin concentrations or exposure, and also the active metabolites of midostaurin were elevated in those patients. So we as an institutional standard of care, we administer posaconazole prophylaxis in standard dose during induction and consolidation chemotherapy for AML, and alongside midostaurin, also in a standard dose. We kept those and prospectively collected trough levels of both drugs at least twice per week via a mass spectrometry method. And for now, I can present some descriptive data of the plasma levels and of the clinically suspected interactions. So this is not so many modeling stuff, but more the clinical perspective. Just a few words on patient characteristics. We had included 30 patients in this study with 65 midostaurin cycles. Overall, the cohort had rather favorable genetics for their AML and rather high survival rates, but I won't go into detail on that. Just here, a brief overview on the posaconazole plasma levels in all patients in that cohort. And interestingly, we see that most patients achieve high mean plasma levels of posaconazole, which are way above the recommended 0.5 to 0.7 milligrams per liter for a prophylactic setting, which was kind of surprising to see that we achieve those high levels. And even more so, in the midostaurin plasma levels were really high, with a geometric mean of 6 milligram per liter. And if we compare these values to the mentioned subgroup analysis from the ratified trial, where the patients who received strong CYP3A4 inhibitors had only 2 milligram per liter geometric mean level, and there's really a large difference. And what we also see was really high inter-individual and also intra-individual variability of plasma levels here, despite sampling was really uniform and basically done as trough levels twice per week. Now, regarding the adverse events, we focused on clinically notable adverse events and all grade 3 and grade 4 adverse events in analogy to the mentioned subgroup analysis from the beginning. We have only 26 patients included here since we're still following up on some of them and the study is not finished yet. And all patients had at least one grade 3 adverse event, which is not surprising in those intensively treated AML cohort. Most of them had a febrile neutropenia, and infections were really present. So 44 infections in 26 patients is really something. So those grade 3 and grade 4 adverse events were mentioned as clinically notable in the licensing trial, as well as cardiac disorders, and I'd like to focus a little bit on those. So in our cohort, we had 16 severe cardiac adverse events. And 8 severe among them in 6 patients. And among those 6 patients, 5 had to discontinue midostaurin, with all of them with high plasma trough levels at the point of occurrence of the cardiac adverse events, with above 2 milligrams per liter, which is really interesting. So most severe were arrhythmias and perimyocarditis in our cohort. We calculated the drug interaction probability score for those patients and for all adverse events, basically, which in the majority of the cases was below 2, so very unlikely that an interaction is present. However, specifically in the cardiac severe adverse events group, the DIP score was above 5, so highly probable that an interaction is present here. This was only in 4.4% of the adverse events. However, this applied for 9 patients, which is really something, a cohort of 26 evaluable patients for now. A few words on invasive fungal disease, since we are still talking about prevention of fungal infection here, not so much about hematology. We observed a rather high incidence of invasive fungal infection, including ERTC MSG possible cases. We had an incidence of 33%, which is excessively high compared to other cohorts, and even the 7 of the 30 patients is really high, but this is in line with published literature from the Italian Siphon group, who also observed higher incidence of invasive fungal diseases in AML patients during induction, and of course with the subsequent higher mortality, which is basically relevant for our patients. Just to come to the conclusion, so there's still many unanswered questions regarding antifungal prophylaxis in the setting of novel targeted treatments in hematology. We had phrased with the European Hematology Association recommendations for midostaurin last year. With a low level of evidence, nevertheless, we recommend conditional for antifungal prophylaxis, especially during induction chemotherapy, as all those patients are basically receiving chemotherapy and are intensively treated, and recommend to monitor them very closely for clinical signs of cardiovascular and pulmonary toxicity, as I showed from our cohort. And we already mentioned the role for TDM, which was the reason why we launched this study. For the future, just to briefly summarize and to give some perspectives and some challenges, we also from the clinical perspective, we believe that involving TDM in clinical trials and sub-cohorts will shed light on this kind of potential interaction, especially with many novel targeted treatments in hematology and oncology. We have more difficult treatment settings with an older and comorbid and co-medicated population in hematology. However, TDM is still challenging regarding logistics in outpatient treatment. And TDM of active metabolites, which I had not mentioned for midostaurin at this point, will also play a role here. And in the end, our perspective should be to optimize our drug dosing and individualize or maybe individualize the dose of our anti-leukemic medication through TDM guidance if possible. With this, I'd like to close. Thank you very much for your attention this afternoon, and I'm happy to take questions.
This interesting paper is open for discussion. Sure, there's some questions. It's best if you go to the microphone, though, or okay.
So many stairs. Or you can just join me here.
So first of all, really great. It was very nice to see all these data being collated. So wonderful job done.
Yeah.
I was curious. Midostaurin is a PGP inhibitor, and you see high exposure to posaconazole. Would that be a possible explanation? And could that also explain, because you showed quite a high number of neurological side effects, might it be that this is posaconazole rather than midostaurin? So I'm curious to hear about what you think of this, Jannik.
Yeah, thank you very much for this question. It's really interesting. We are still in the process of interpreting this data, because we actually, at least at our center, did not have that kind of comprehensive data so far. And in the case of neurological adverse events, I will probably agree with you that this can also be attained or attributed to posaconazole. But for now, I can't really give you a definite answer on this. But yeah, the adverse events are still need to be differentiated on toxicity of the posa or the midostaurin or any other medication the patient received.
Okay. And do you want, because you already alluded to the two active metabolites that are being formed from midostaurin, do you want to spoil anything on the findings that you have with regards to changes in parent to metabolite ratio?
Well, not being a pharmacologist, I can just say most clinicians are not really aware of the fact that the active metabolites are maybe of higher interest than the midostaurin itself. We do not have a TDM method for them, so I couldn't include them in this analysis here. Sorry for this. You got me here. But yeah. This will definitely play a role and will be established in our clinic, and should be established if a hematology clinic decides to use TDM. The active metabolites should be monitored as well.
Yeah. Okay, thanks. Very cool data again.
Thanks again.
Thank you.
Thank you.